So I think we can start. Welcome all to our ASBMR Clinical Workshop series, which were organized on behalf of the ASBMR Early Stage Investigator Committee. The topic of today's webinar is entitled, When Can We Stop Osteoporosis Treatment? Professor Dr. Richard Eastell, international expert on the field, together with his PhD student, Dr. Lorenza Mattia, will present a clinical case and discuss the various considerations regarding stopping osteoporosis treatment. Richard Eastell is endocrinologist and professor of bone metabolism. He is the director of the Mellenby Center for Musculoskeletal Research at the University of Sheffield. And he followed his endocrinology training in Edinburgh, Northwick Park, and at the Mayo Clinic. He leads a research group on the pathogenesis, diagnosis, and treatment of osteoporosis. Of particular note is his contribution to the use of bone turnover markers and the development of treatments for osteoporosis. His work has been recognized in 2014 by the Barter Award from the ASBMR and in 2020 by the Clinical Endocrinology Trust Award from the ESC, the European Society for Endocrinology. He's a fellow of the ASBMR and a former member of the ASBMR Council. Lorenza Mattia qualified in medicine in 2015, after which she trained in endocrinology and metabolic diseases in the University of Rome. She spent 6 months at the Academic Unit of Bone Metabolism and Metabolic Bone Center of the Northern General Hospital, the University of Sheffield in the UK, which is headed by Professor Dr. Richard Eastell. Her work mainly focused on osteoporosis and the use of bone turnover markers. In November 2020, she started her PhD program on novel bone biomarkers in diabetic bone disease, with the joint supervision of Professor Pugliese from University of Rome and Professor Eastell from University of Sheffield. Today's session will be moderated by Dr. Elena Zurdi from Dresden University in Germany and Dr. Sebs Ramchand from Harvard University, USA. At the end of the presentation, there will be a 15 or 20 minutes time for question and answers. And I would like to ask you, please use the question and answer button tool for these questions and not the chat function. You can already submit the questions during the presentation, which we encourage so that the moderators can structure these. And I would like now to hand over to the speakers. Thank you.
Okay, can you see the presentation? Okay, hello to everybody. Thank you, and it's a very pleasure for me to participate at this ASBMR Clinical Case Workshop. And the topic of our talk is, when can we stop osteoporosis treatment? So we will try to answer to this question through a clinical case. And we had a 67-year-old lady who referred in our clinics in 2015 because of a shoulder fracture due to a low trauma. She had osteoporosis with a BMD T-score of -4.2 at the spine and -3 at total hip. We did a vertebral fracture assessment, and that showed fractures at the spine. And here, as you can see in the BFA, we had a vertebral fracture at T12 and L2. In her past medical history, she had a cervical cancer and an early menopause since the age of 40. Since then, she was on hormonal replacement therapy until the age of 52. We did some investigations that we routinely do in our department. All of these were normal. And of course, we also assessed the bone turnover using the P1NP that was 60 microgram per liter. So this is the algorithm from the Endocrine Society Clinical Practice Guideline for postmenopausal osteoporosis. And our patient is a very high risk patient because she had multiple spine fractures and a bone mineral density T-score that was below -2.5. So we have the recommendation to start as first-line therapy, oral or intravenous bisphosphonate. So what we did, we recommended to start alendronate 70 milligram per week and repeat P1NP at 6 months. And we know that there are several biomarkers used to assess the bone turnover, to assess the bone resorption and the bone formation. But amongst these markers, the CTX and the P1NP are the reference markers for bone resorption and bone formation, respectively. What about the P1NP? It is the amino terminal propeptide of the type 1 procollagen. It is cleared by receptor in the liver and circulates in an intact form, but also as fragments. And the IOF and the CTS proposed an algorithm to assess the adherence to bisphosphonate treatment. And they suggest to perform a baseline bone turnover marker, P1NP or CTX, before starting the treatment. Then we should measure again at 3 months after starting the treatment and see if there is a decrease in the levels of bone markers that are more than the least significant change. In this case, the patient will continue the treatment. If not, we should reassess the treatment. In Sheffield, we developed an algorithm provided to general practitioners in order to monitor oral bisphosphonate treatment. The GP should assess a baseline P1NP or CTX before start the treatment, then check the compliance to the treatment at 1 month, and at 6 months, repeat the measurement of the bone marker to check the response. So we define a P1NP good response as a decrease that is more than 10 microgram per liter, that is considered the least significant change, or a decrease below 35 microgram per liter, that is the premenopausal mean. After that, if there is a good response, the patient will continue the treatment for 5 years, and then we will reassess the fracture risk using a DEXA and consider a drug holiday. But if after 6 months of treatment, there is a bone turnover marker not suppressed, we should reassess the treatment. And first of all, we should check the adherence to the treatment, but also check if there are other issues, for example, conditions that could impair drug absorption or secondary causes of secondary osteoporosis. And we also well know which are the effects of the oral bisphosphonate on the bone turnover markers, thanks to the results from the TRIO study. And here in this slide, we can see the effect of alendronate on the bone formation markers levels. In particular, in the blue line, we can see the effect on the P1NP that decrease after 12 weeks of treatment. So going back to our patient, she repeated a P1NP measurement at 6 months, but it was 55 microgram per liter. And she was well compliant, but so we could interpret this result as a no-response to alendronate treatment. So the GP referred back the patient, and we decided to start Zoledronate infusions. She had her first 2 infusions in 2016 and 2017. And during the follow-up, the P1NP was well suppressed because it was 15 microgram per liter. There were no new fractures. And this is the, we are showing you just the spine DEXA, but there is a BMD gain of the spine, even though there are some degenerative changes. But there is also an increase in femoral neck BMD T-score that was above the threshold of osteoporosis, and an increase of about 5% since this Zoledronate infusion started. So we did the third infusion in 2018, but the patient had an episode of paroxysmal atrial fibrillation. So now we have the first question for you. What would you do? Would you stop Zoledronate infusions? Would you continue Zoledronate infusions up to 6 years, change to teriparatide, or change to Denozumab? So, just 36% of you choose to stop Zoledronate infusions, but about 30% of you to continue up to 6 years, and then 20% change to teriparatide, and just the 10% of you choose to change to Denozumab. So what we did. So her medical advice was to stop infusions and to change to Denozumab because of her high risk of fracture and her prior vertebral fracture, multiple vertebral fracture. But the patient preferred to stop infusions and defer starting the new treatment. So we just continue with the monitoring her, and we continue monitoring the P1NP levels, and they will remain suppressed over the next 2 years. But what do we know about the occurrence of the atrial fibrillation during Zoledronate infusions? Well, from the Horizon trial, several adverse events have been described, but arrhythmias were effectively more common in the zoledronic acid group compared to the placebo group. Moreover, here we are showing which are the effects of the 6 years of Zoledronate infusions on femoral neck bone mineral density. Here in the graph, we can see in the orange line the patients treated with Zoledronate for 6 years. And in the gray line, we can see the patient treated for 3 years, followed by 3 years of placebo showed in the dashed line. Well, after 3 years of treatment, in both of group, the patient had a BMD gain of about 4%. Then in the orange group, the BMD remained stable, and there was a small decrease in BMD, femoral neck BMD, in the placebo group, even though it was very tiny. It was just 1.4% difference with the treated group. Moreover, we have this ASBMR algorithm that suggests a drug holiday if there are no new fractures during the therapy and if the HIP BMD T-score was above -2.5. However, here we are showing you the reduction for fractures for continuing bisphosphonates. And in the top of the slide of the graph, we can see the alendronate treatment given for 10 years in the FLEX study. And in the bottom, the Zoledronate infusions up to 6 years, that is the Horizon trial extension. Well, both of these groups had showed a benefit in the vertebral, clinical vertebral and morphomedical vertebral risk of fracture reduction. Going back to our clinical case, in 2020, during the follow-up, the patient complained for a back pain after lifting her grandchild. We did another VFA that showed us the presence of a new fracture at L3. The bone mineral density remained stable, and the P1NP was 30 micrograms per liter, so it was suppressed. Well, now we have the second question for you. What would you do? Would you start Zoledronate again for 3 once-yearly infusions? Would you start Denozumab or continue monitoring without any treatment, or start teriparatide? Okay, I'm very happy to see these results because most of you decided to start teriparatide, as we did. We decided to start teriparatide for 2 years, and it will be followed by an anti-resorptive treatment, of course, and we will decide probably for Denozumab because the patient can't use Zoledronate because of the atrial fibrillation, and she was a non-responder to alendronate treatment. And this is the algorithm that support our decision. So bone turnover markers could help the clinicians in the management decision, because if there is a bone mineral density decrease or fracture during the treatment with bisphosphonates, but as in our case, the bone turnover is suppressed, we could consider anabolic treatment.
Thank you, Lorenza. And I'm going to say a few words now about the use of drugs for osteoporosis in the long term. And in our patient's case, we saw that she helped us with a choice. That she didn't want to go on to a further treatment after 3 years of Zoledronate. But we do have evidence that we can use the drugs for longer than that. And there are reasons why we might want to think about stopping after a few years. And I'll go through this. So next slide. Next slide, please. So I'm going to be making use of the Endocrine Society Clinical Practice Guideline that Lorenza had mentioned, and focus on two drug classes where we've got quite a lot of information on long-term treatment, namely the bisphosphonates. And here I'll be talking particularly about the concept of drug holiday, and Denozumab. And here I'll be talking particularly about the concept of follow-on treatment. So in our practice guidelines, we made the point that we recommend initial treatment with bisphosphonates to reduce fracture risk. And there are 4 of those that have been well studied. And the one that we're just a bit cautious about is Ibandronate, because we don't have evidence for reduction of hip fractures. Next slide. And we have very good evidence that these drugs are effective in reducing fractures. So we did a meta-analysis as part of our guideline. And on the left, you can see for vertebral fractures that all 4 bisphosphonates clearly reduce the relative risk of vertebral fracture, somewhere between about 35% and 70%. And on the right, you can see that except for Ibandronate, all of them reduce hip fractures, somewhere between about 30% and 50%. So clearly efficacious drugs. Next slide. And the trials were extended over long periods of time. So you've already seen some data from the Zoledronic acid or Zoledronate trial, the Horizon trial. So Lorenza showed you the extension 1 period. We did actually have an extension 2 period that went out to 9 years, but there was no benefit in going out to 9 years. So we don't usually recommend Zoledronate beyond the 6 years. Alendronate, she told you a little bit about the FIT study, which was up to 5 years long. And then the FLEX study was a period after the FIT when patients were randomized to continuing alendronate or not. And I'll show you a bit more about that in a moment. And similarly with Rezidronate, we've got data going out to 7 years. Next slide. So this is just to make a really important point about bisphosphonates. And that is that when you stop them, they continue to work. And so here we're showing with alendronate over the first 4 years, the BMD increase at the femoral neck on the left-hand panel, the FIT trial. And then these patients, once they got to the end of that 4-year period, were randomized again to either continue alendronate or to a placebo. And so if they received alendronate, they just maintained their bone density. But if they went on the placebo, they did have some bone loss. It's just that they didn't get back to baseline. So even after a 5-year period of stopping, they haven't returned to baseline. So this shows you that there's a long-term benefit of giving a bisphosphonate even after you stop. And if bone turnover markers were measured in this study, and bone turnover markers remain suppressed for a number of years after stopping bisphosphonates. And we think it's because the bisphosphonate is taken up by the bone and seeps out over a period of years. Next slide. And just to show how valuable we found bone density testing, we recently conducted this meta-regression where we looked at the various clinical trials and plotted on the x-axis the BMD difference in total hip BMD between the active and placebo groups, and on the y-axis the odds ratio in this case of vertebral fracture. And you can see the bubbles that are describing residronate, alendronate, and zoledronate fall on this line. And the greater the increase in BMD, the greater the reduction in fracture risk. And that was true for other fractures like hip fracture and non-vertebral fracture. Next slide. Now, the next point we made was that after a period of 3 to 5 years, women who remain at high risk of fracture, they might continue for another 3 to 5 years, whereas those that are low to moderate risk should be considered for a bisphosphonate holiday. So where did this idea come from? Next slide. So the main reason for this is the observation some time ago now that bisphosphonate therapy can be associated with atypical fractures of the femur, either in the subtrochanteric region or in the shaft. This image here shows subtrochanteric, and you can see how the fracture line is transverse, there's no comminution, and the cortices are thick. So these are all classical features. So many subtrochanteric fractures may have nothing to do with bisphosphonates, but about 10% do, and they have these classical features. Next slide. Now these particular type of fracture really scared the medical profession and patients. And they were described in about 15 years ago. And so after the year 2008, you can see that the number of prescriptions for bisphosphonates has gone right down. And it's mostly around fear of side effects, such as atypical femur fracture or osteonecrosis of the jaw. And so it's a major issue that we have to address and understand better. And it's a reason for considering stopping bisphosphonate therapy. Next slide. So we carried out a study to characterize the time course of atypical femur fracture in women who were taking bisphosphonates. And we did this in a large cohort from the Kaiser Permanente Southern California healthcare system. And if you look at the graph on the left, you can see that the longer that the patient took the bisphosphonate, the more likely they were to have an atypical femur fracture. And we were quite confident that these were atypical femur fractures because the beauty of this study is that we had access to all of the radiographs, and so we could have them viewed by an expert radiologist. And you can see that up to about 5 years, atypical femur fractures are not very common, but beyond 5 years, and particularly beyond 8 years, they do become very common. And once you stop them, if you look at the panel on the right, after you stop them for about 15 months, the rate becomes low again. And so probably if we have a drug holiday between 1 and 2 years, that should suffice for the risk to go down again. You could monitor this with BMDs, I'll show you in a moment, or with bone markers if you wanted to individualize the advice. Next slide. So this just shows you, if you take what happens to lumbar spine BMD on the left, after stopping Zoledronate, which is the Horizon trial, or alendronate, which is the Flex trial, you can see that basically there is no bone loss in that 3-year period after stopping the drug. So a special feature of bisphosphonates, true for Zoledronate, true for alendronate. There was some bone loss, if we look on the right at the total hip, particularly with Zoledronate, not very much with Zoledronate. So some bone loss, but still not back to baseline after 3 years. So this is a special feature of bisphosphonates. It's the only drug for osteoporosis that we know of that has this special feature of continuing to work even though the drug has been stopped. Next slide. So much for bisphosphonates. So the recommendation then, stop after 3 years with Zoledronate if it's a mild case, 5 years after Zoledronate if it's a mild case, and then give a drug holiday for a year or 2. So what about other drugs? What about Denozumab? So again, if women are at high risk of fracturing, we recommend Denozumab as an alternative to bisphosphonates. The evidence was strong, so there are four circles here, and we suggested that we have to be careful with Denozumab because the effects reverse after 6 months if it's not taken on schedule. And so we must not take a drug holiday, and we must not interrupt treatment because we'll lose all the benefit of the drug, as we'll see in just a moment. So the Denozumab data is based on a large clinical trial, the FREEDOM trial, which was in over 7,000 postmenopausal women with osteoporosis. And for the first 3 years, they were randomized to receive Denozumab or placebo. The placebo is in green in the graph on the right, and the active is in blue. And you can see the big increase over the first 3 years of about 10% or so in BMD. So it's a very good effect. And then both groups after 3 years were given the Denozumab, and you can see that they continue to have increase over the next 7 years, out to 10 years. So 10 years of data, which is really helpful to know that it continues to work over that period. Now, there were 1 or 2 side effects that we've heard about with the bisphosphonates. Namely, there were a couple of cases of atypical femur fracture, and there were 13 cases of osteonecrosis of the jaw. So again, there are question marks as to how long we should give the Denozumab for. So we might consider, should we have a drug holiday with Denozumab? But let's see what happens when we stop Denozumab. Next slide. Oh, sorry, just one thing to say before I say that. So we showed the BMD data on the last slide. Here we're showing the fracture data on the left for new vertebral fractures, showing how the group that received Denozumab had much lower risk than those that took placebo by about 70%. And then on the right, much lower, a lower risk of non-vertebral fractures shown in the blue compared to the placebo in green. So highly effective drugs. And if we show you that graph again, that relates that's fine, Lorenza, the percentage difference in BMD on the x-axis and the odds ratio of vertebral fracture on the y-axis. If we now show you what happens to Denozumab, you can see that had the biggest increase in BMD and the biggest reduction in vertebral fracture. So again, BMD is telling us what actually happens to fracture risk. Okay, next slide. So then we said that we might want to reassess the fracture risk after 5 to 10 years, and those who remain at high risk of fracture can continue or else go on to other osteoporosis therapies. But now notice how, rather than giving it 4 crosses, we give it 1 cross because we have such little data. And when we wrote these guidelines 2 or 3 years ago, we had practically no data at all on this topic. And so it's an area where we're needing much more research. But let me show you what little information there is. So next slide. So this is showing you what happens when you do stop Denozumab. And so in this trial, postmenopausal women were randomized to receiving Denozumab or placebo for 24 months. And then the red arrow showed the discontinuation of Denozumab. And you can see that whether it's the lumbar spine, the total hip, or the 1/3 radius, there's accelerated bone loss over that first year of stopping the Denozumab. And I'll just click 1 more time, Lorenza. And this accelerated bone loss has since been reported to be associated with multiple vertebral fractures, both in a clinical trial setting and also from case reports. And we think it's because of the acceleration of bone loss. Next slide. And the acceleration of bone loss, we think, is a consequence of an overshoot in bone turnover. So again, if we just show when the treatment was discontinued, on the left we have CTX, the bone resorption marker, and on the right, P1NP, the bone formation marker. We can see that when the Denozumab is stopped, the bone turnover doesn't return to baseline, to the placebo level. It overshoots by about 60% for CTX and about 40% for P1NP. So basically, for at least a year, the patient goes into a high turnover state. And we know from other clinical settings that whenever a person is in a high turnover state, the risk of fractures, particularly vertebral fractures, are increased risk. Next slide. Here's just an example of a case report of a 51-year-old woman, 5 years since menopause, and she had a low BMD, was given Denozumab for 3 years. And after the 3 years, her BMD T-score had reached -1.8, so it's reached the goal of therapy. And so the treatment was stopped. And then 8 months later, she developed severe back pain. And if you just click on that one, Lorenza, we can see that that's fractures of the T12, L1, and L3. And so this is a major worry for us now about if we stop the Denozumab, we might see fractures. So how do we work out who are the patients most at risk of this? So these are some of the risk factors that we've learnt to be concerned about. That there's those patients who are on a long duration of Denozumab, particularly those who are more than 4 years. Those patients who've had a big gain in their BMD on treatment, those with prior vertebral fracture, the younger women, surprisingly, women with patients with chronic kidney disease, and those who've had vertebroplasty. These all seem to be those at risk of having these vertebral fractures, as are those patients who've had a lot of bone loss of the treatment. So we know some things about the risk factors and who to watch out for. And so, but what do we have to give these patients? So we haven't had very much clinical trial information on this. This is one of the nicest clinical trials from Denmark, from Anne-Sophie Solling. And this shows what happens when you give Zoledronate after stopping Denozumab, which has been given for at least 4 years. And so these patients have been on long-term Denozumab. They've now stopped, and they received the Zoledronate either at the immediately at the time when they should have received their next dose of Denozumab in blue, 3 months later, shown in red, and up to 6 months later, shown in green. So you can see that after giving the Zoledronate, there's a dip in the CTX, but it's a transient dip, and unfortunately, it isn't maintained. And so there must be a very strong drive for bone resorption after stopping Denozumab, which can't be suppressed by the usual doses of Zoledronate. And the bottom graph shows how lumbar spine BMD, we don't prevent the bone loss. That the lumbar spine, there's whichever regime you use, is about a 4% bone loss. And so a bit of a challenge for the future about what we do in patients where we want to stop the Denozumab after it's been given for 4 years or more. Next slide. So to summarize what we think about stopping therapy is that we do have these treatments that we can use for long term, and their evidence-based goes up to 10 years. And we have several practice guidelines, and I've just shown you the Endocrine Society ones, but there are several more. And often there are national guidelines. And we often use bisphosphonates as a first-line treatment. And if we have a mild case of osteoporosis, we might stop the BMD, might stop the drug after 5 years for oral treatment and 3 years for intravenous treatment. And we do that because we think we'll be reducing the risk of atypical femur fracture without increasing the risk of fragility fractures. And then with Denozumab, here, we quite commonly use that as the first-line treatment as well, but we don't know the optimal duration. The clinical trial shows us that it works up to 10 years, so certainly we could be considering using it for 10 years. We just don't quite know what to do after that. And at the moment, we have this problem that when we do stop the Denozumab, we have accelerated bone loss, which is associated with vertebral fractures, and we can't prevent it with standard doses of bisphosphonate. So it's an area where we're needing more research. And so for the time being, we tend to continue for as long as we are able to with Denozumab. So that's trying to answer the question with the commonly used drugs that we have, when should we stop treatment? So with that, I'll stop and take any questions that you might have.
Thank you, Drs. Mattia and Dr. Eastell. I'd like to open up the session now for questions and answers. We already have some, but please encourage you to use the Q&A function of this platform to submit any other questions you have. So I'll start by, we've got some questions related to the case itself, so I might start off with those. The first two are regarding the use of bone turnover markers, and both attendees have asked why P1NP was selected to use for monitoring rather than CTX in this particular case.
Great. Lorenza, do you want to answer?
Yeah. Yeah, we chose the P1NP because it's easier in clinical practice, because you don't need, as with a CTX, a fasting state. So you can take blood samples without any problem during the day. It doesn't need fasting state. So it's easier for GPs, general practitioners, or in clinical practice to measure P1NP.
Thank you. The second question, why was alendronate shifted to zoledronate even though there was no satisfactory response?
Yep. So there was no satisfactory response. And so for whatever reason, the patient wasn't responding to the alendronate. And so we checked to make sure that the patient was complying, and they were. And so if there's no obvious reason, perhaps they're not absorbing it very well. We know that alendronate's only about 1% absorption or even less. And so the patient just wasn't responding. So it seemed to us logical to consider a parenteral form. And zoledronate is often effective when alendronate isn't. So that was the reason for going across from alendronate to zoledronate.
Tamara Vokes asks, and this is related to her initial therapy, would you have considered using anabolic therapy up front? I'm assuming she's probably talking about 2 years of teriparatide followed by zoledronate, rather than start with the bisphosphonate and then go on to teriparatide.
Yeah, thanks for that, Tamara. So Tamara, one of the challenges about writing guidelines is that you have you're writing it for people from many different countries, and so in my country, it's unthinkable to be able to give teriparatide first, and that's because in the UK, money, the cost of drugs, is taken into account a great deal. And the strategy of giving teriparatide first and then a bisphosphonate is extremely expensive. And so we're advised by our governing body, NICE, that we give alendronate as the first choice. And if the response is poor, if the patient has further fractures, unable to tolerate, then especially in cases of severe fractures like our case here, then you go on to teriparatide. So it's very much a question of health economics as whether you should go with teriparatide first. If I didn't have to worry about health economics, I think that in a case like this, it would be a great idea to give teriparatide first, because she's got severe osteoporosis, and having given the teriparatide, hopefully she'll go through a better course, because we know how effective teriparatide is. So, but it can't be done in every country that you give teriparatide first. You would normally give the least expensive drug first, like alendronate.
There's just 2 more questions here about bone turnover markers, just to finish off that part of the talk. So Nahid Rhiannon wants to know, is P1NP use now a guideline for general practitioners?
Yep. Off you go, Lorenza.
Well, we are doing a study to evaluate the use of P1NP from general practitioners in clinical practice. It is a real-world study, so at the moment it is not a guideline, but it is a recommendation. It is an algorithm that we propose to the GPs, and yeah, in the last years we are trying to give the advice to use it more than the monitoring with DEXA. And now we are having probably the results very soon of our trial for the use of P1NP by GPs.
Yeah, and we introduced the P1NP about 10 years ago in the UK in our own clinical setting, and so the GPs really like it because it means that they don't have to do BMD at 2 years, so they save money and they're in control. So it's very popular with the GPs.
And if you don't have any baseline values of CTX or P1NP, is it still useful to monitor bone turnover markers?
Yes. Lorenza, did you want to answer that?
Yeah, yes, it is useful because as I have shown you, a good response could be explained as decrease that is more than a significant change. And so, of course, it is considered from a baseline value. But we have also a reference range that is, for example, for the P1NPs is 35 microgram per liter, that is considered the premenopausal mean. So during the treatment with anti-resorptive treatment, of course, we expect to have a suppressed P1NP. So yeah, it's useful, even though if we don't have the baseline, because we can see if there is, for example, a level below 35.
I see one question here about atrial fibrillation and the use of zoledronic acid, and then the rest are all about cessation of meds. So I might ask you this, and then I'll hand over to Eleanor to go through the rest of the questions. So in a patient with long-standing atrial fibrillation, would you ever start zoledronic acid?
Yeah, so we don't really worry about zoledronate in the setting of atrial fibrillation. If it's established, then it's established. It's people who are in sinus rhythm, where if you've had a past history of paroxysmal atrial fibrillation, you're worried that you're going to trigger it again. It's the triggering that you seem to get with zoledronate. So if they're already in atrial fibrillation, then we don't worry. Exactly.
Thank you.
Thank you. We'll continue with some more questions. We have plenty of questions here. We will try to answer as many as possible. Some of them pertain to the subjects of atypical femoral fractures. And there's a question of Dr. McLang. So you mentioned sometimes bisphosphonate holidays and then restarting them. And he wants to know what happens to the risk of AFF if bisphosphonates are restarted after a 2-year holiday.
So the very short answer is we don't know. And so all we can think of is just going from first principles that we think these atypical femur fractures have got something to do with very low turnover, bone turnover. And it seems like you need to have several years of having that very low turnover in order to get a fracture, and therefore we have to guess that once we restart after a drug holiday, that it'll take a few more years before the risk of atypical femur fracture. But it's purely a guess. I don't have any data to support that. But it's one of these things that hopefully, as the years go by, we'll be able to look at studies like the Case Permanente and other observational cohorts and perhaps get the answer, but we definitely don't have it now.
Yes, there are also some studies looking into genetic background of patients with AFF, and maybe there, if we can identify some signaling pathways. From Dr. Hauser, we have a question of if alendronate non-responders are at lower risk of AFF than alendronate responders, and if one could restart the clock regarding AFF risk when switching to zoledronic acid in this case.
Yeah, so we've looked really carefully at the bone turnover and the bone biopsies from patients with AFF, and it's so hard to know whether you can individualize bone turnover and the risk of atypical femur fracture, because there are so few people. So in the clinical trials, such as the Horizon trial, such as the Zoledronate trials, the alendronate trials, there were so few people who actually had atypical femur fractures, that even if we had bone markers in them, and most trials we only do bone markers in a subset, that we just didn't have clear enough information whether those people who were getting the atypical femur fractures were the same people who were getting the lowest bone markers. So that would be my working hypothesis, that it probably is, but we don't have the evidence to support that. So it's one of those things that is likely to be the case, but we just don't know. We just don't have the evidence, and we don't have the evidence either from bone biopsies because there are just far too few of them.
Just the last question on AFF from Dr. Dersko. This pertains a patient who suffers AFF under Denozumab, and this is a treatment where he has had an excellent response, but now suffers an AFF. What treatment would we do after that?
Well,
very tricky question.
I know. So what on earth you do with a patient with AFF is one of the real challenges. And so quite a few physicians will go on to treat with teriparatide once you've had an AFF. And then the theory is, if you give a 2-year course of teriparatide, then maybe you've kind of woken up those sleepy bone cells, and then at the end of the 2 years you can come back in with anti-resorptive drug, and that will be a safe approach. So that will be one approach. An alternative approach is to go with a mild anti-resorptive drug, by which I mean, raloxifene, hormone replacement therapy, those kind of drugs. If they might be suitable, that would be another alternative, because those drugs haven't really been associated with atypical femur fractures in the same way that bisphosphonates and Denozumab have been.
Thank you. We have a question from Dr. Tuff. She wants to know, how quickly does BMD decrease and bone turnover return to baseline with Zoledronate? And given that you have done this excellent trio study in Sheffield, maybe this is also a very pertinent question.
That's right. Thank you for that question. Yeah. So I published a paper a long time ago, based on the Zoledronate trials, where we looked at NTX when you stopped Zoledronate, and it looked like you got quite good reversibility, quite quickly. But in the trio study, where people were randomized to Zoledronate or abandronate or alendronate, and then after a couple of years they were stopped, it looked like the bone markers were fairly similar for each of the 3 oral bisphosphonates. And by 2 years after stopping, they were almost exactly the same with the mean levels of the bone markers. So although I used to think that Zoledronate had a more rapid offset, I'm just not so sure anymore. And it's one of these things that needs further investigation. But I suspect that Zoledronate's in the same category as ibandronate and alendronate.
Thank you. Another question from Dr. McClung. This pertains the difference between alendronate and zoledronate and drug holiday after 5 years of alendronate versus 3 years with zoledronate. The basis of this.
Yeah, so Zoledronate's a really tricky one, because the question, Mike's question, implies that we know just how strongly the association is between Zoledronate and atypical femur fractures, and it's one of these really tough things that we're just not sure, because so many patients who get Zoledronate have previously had alendronate or another oral bisphosphonate. So to dissect out whether there really are people who will get Zoledronate and get atypical femur fractures is a little bit tricky. But if we just step back and go back to kind of basic principles, then the effect of Zoledronate on bone markers and on BMD change tends to be more persistent after stopping. So when I was saying it looks like atypical femur fracture effects go away with alendronate, which is the most important treatment in the Kaiser Permanente study, go away between 1 and 2 years, it may be longer for Zoledronate. It may be more like 4 or 5 years. So Mike's point is well taken, that you may want to wait a bit longer. And this is why at the moment in all my patients, when we're doing drug holidays, I do bone markers, because I'm learning what is the key thing about individualizing the treatment and how long you have to wait before the bone markers come up. And with bone markers, I believe I can do that.
And we have a question from Dr. Bock, and this is about bone turnover markers and a based algorithm on bone turnover markers for the management of patients after DMAP discontinuation. You presented the study by Bente And maybe you want to comment some more?
Yeah, so after you stop DMAP, then it seems like you're reaching the peak in the bone turnover markers somewhere around about 3 to 6 months after the time where you would have given the last dose of Denozumab. And so it seems that if you wanted to pick up a person who's going through a period of very high bone turnover, that will be the time that you would measure. And when you look at the data from the clinical trials, there is quite a lot of heterogeneity of bone turnover in the offset period after Denozumab. So it might be quite informative to differentiate those people who are really not getting much of an increase in bone turnover and those people who are getting a huge increase in bone turnover. So I think I would get a measurement at 3 months after the date of the last what should have been the last dose of Denozumab.
Great, thank you. So the last two major topics here, we have a lot of interest about in Denosumab cessation, but also in the atrial fibrillation. I'm going to try and finish some of those ones very quickly. There's a question here about whether people can develop paroxysmal atrial fibrillation months after stopping an oral bisphosphonate.
Yeah, so the interesting thing about atrial fibrillation is it's only been seen with intravenous bisphosphonates. So we saw it in the Horizon trial of Zoledronate. And then when we went back to the clinical trials of Pamidronate, it was found that Pamidronate also causes it. So it seems to be that you're required to have intravenous bisphosphonate, and it occurs in a week or two afterwards. So it wouldn't happen like 6 months later. It would just happen in the first couple of weeks. And therefore, it was thought it could be some sort of metabolic disorder relating to the calcium level or phosphate level, but we were never able to pin it down as to exactly what the mechanism was. But it's an acute phenomenon.
Thank you. There's a question here about if somebody did develop paroxysmal atrial fibrillation while on a bisphosphonate, would that be a contraindication to use that treatment again in the future?
Well, I think for intravenous bisphosphonate, where there's a clear-cut association, I think the answer is yes. I wouldn't use it again. Because you're running a risk. It's it's a condition, as you know, that can be linked to stroke, and you don't want to be taking that kind of risk, really. The thing about oral bisphosphonates, there have been one or two papers suggesting that perhaps there's an increase in the risk of atrial fibrillation. I'm just not totally convinced myself. So I'm not sure that I would worry so much about oral bisphosphonate. It seems that you have to have that acute effect of the bisphosphonate to get the atrial fibrillation.
Thank you. And I think a number of attendees want to know, post-Denosumab, what are your thoughts about starting anabolic therapy? So either teriparatide, abaloparatide, or romosozumab. If you could please comment on each of those treatments.
Great. So I don't know. Yes. So in terms of teriparatide, then we do know that if you give teriparatide after Denozumab, and we know this from of course the trials from Boston, from Ben Leader, that when you give the teriparatide after Denozumab, it's a really disappointing increase in BMD. And so one of the points that Ben's been making is that it's not a great strategy going from Denozumab to teriparatide. But of course, if you are where you are, it may be a good choice. But just don't expect the usual increase in BMD with the teriparatide. With romosozumab, there was a trial that was published a couple of years ago of going from Denozumab to romosozumab. And as you know, romosozumab normally causes a huge increase in BMD in the first year, and you just don't get the huge increase in BMD. You get very little change in BMD. And so again, it's just like the Denozumab teriparatide story, is you do seem to attenuate a lot of the anabolic benefit by giving Denozumab first.
Thank you. There are a number of comments here, and Dr. Eastell, I'm wondering if you'd like to add to this about, the duration of Denosumab that we have studied so far is up to 10 years. And so some would advocate stopping at 10 years because there is an absence of data. But there's a lot of comments here to say that in most of internal medicine, we do not have long-term data, even, for example, for diabetes treatments that go beyond 5 to 10 years, and yet we continue these therapies long-term. Should we be happy enough that we have enough data and we should continue these treatments long-term with the data that we do have, rather than ask for really long-term data?
Well, hopefully one of these days we will get longer term data, because there'll be data from observational studies and clinical cohorts. So we will get more information probably. But for the time being, the approach I take with patients is to say, well, you've got to 10 years. We don't have any data beyond this point, but you're doing well. You responded well with your bone density. You're not having fractures. You may have an increased risk in your osteonecrosis of the jaw, but we just can't be sure about that. But why don't we just keep going? That's what I would say at the moment. And then review them, and in 2 or 4 years' time, and maybe in 2 or 4 years' time, we will start to see some data coming through on longer term use of Denozumab, and then we have some evidence base over which we can be giving our advice. So that's what I do with my own patients.
Thank you. There's a question here about duration of Denosumab therapy and risk of multiple vertebral fractures. In the trial from Bone, the 2-year use of Denosumab was not associated with an increased risk of multiple vertebral fractures after discontinuation. Would you say a shorter duration of 2 years or less is sort of safe or protective of patients developing these fractures?
Yes, I think so. There was a very early paper where just 1 dose of Denozumab was given, and at the end of the 6 months, there was no overshoot. So in those first, but we just don't know between 6 months and 2 years what happens. So when you give it for 2 years, for sure you get the overshoot. So we don't know whether it's 1 dose, 2 doses, or 3 doses when you start to see the overshoot. That hasn't been tested yet, and maybe someday somebody will test it. But certainly after 1 dose, you don't get the overshoot. So a short course, probably nothing to worry about.
And there's a question about starting Denosumab in younger patients because of the duration at which to treat.
Yeah, so it's exactly just like we've been talking about, really, isn't it? Yeah. That a young person, if we talk about somebody who's 50, 55, and they've got severe osteoporosis, they might need quite a long course, and the course might well be beyond 10 years. And so it's all the issues we just talked about, that once you get to the 10-year time point, you have to explain the situation, that you're getting into an evidence-free zone, and that may be the right choice for that particular patient, but you have to explain to them that we're running beyond the evidence. And so I do accept what you were saying earlier, that some with other treatments we go beyond the clinical trial duration, but we just need to know we are in a little bit of an evidence-free zone, and we are a little bit worried that some of the side effects, like the atypical femur fracture, like the ONJ, they could be related to duration of therapy, and therefore we need to be careful.
Thank you. And I guess as a follow-on, is there then an ideal patient profile that you would choose when selecting Denosumab as a treatment option, because stopping it has become so problematic?
Yeah. So for me, if I possibly can, I give Bisphosphonates. And then I tend to use Denozumab in those patients where I can't use those bisphosphonates. That tends to be what I use because of this period of uncertainty. But hopefully this period of uncertainty will go away once we know what to do when we want to stop Denozumab.
Okay, we might take this last question and then we'll close the session. This is about the relative risks of a 3 to 4 month gap in the treatment after discontinuing anabolics such as teriparatide or baloparatide before shifting to an anti-resorptive treatment. I think the question is what the risks are in stopping for that short duration of time.
Yeah, so nobody's ever kind of reported any big problem with fractures or anything in that short period of time. It's a period where bone turnover, if anything, is decreasing rather than increasing. So you wouldn't have thought it would be a particular period of high turnover and therefore more fractures. I don't think it's the equivalent of stopping Denozumab, but I think it's just good practice that when you're looking after somebody with teriparatide, you're seeing them regularly over a 2-year period, so you can usually plan that at the end of that period you're going to give them an appointment for the Zoledronate or the prescription for the Alendronate. I've not found it a problem myself of having a big gap after a course of teriparatide.
Perfect. Well, thank you so much. That was a whirlwind of questions. I think we got through about 30 questions, so thank you both. I'm just going to hand over now in the last 1 to 2 minutes to Elizabeth Winter to close the session.
Yeah, thank you all for this very, very interesting presentation discussion. I think the presentations were excellent. And I also think that the number of questions, there were even questions left, illustrate how enthusiastic everyone got by this presentation and its discussion. So thank you, speakers, and also thank you very much, all attendees, for this vivid and fruitful discussion. I would like to end with announcing our next clinical case workshop on June 15th with the title Osteoporosis Genetics. I hope to also see you all there for, again, a very nice presentation and discussion. And herewith, I would like to close this very, very nice session. Thank you all.